So today I want to show you our work when we use Plasmodium coatneyi infected macaques and treated with methylene blue, and how we use this model to understand the severity of the infection with Plasmodium falciparum. So first of all, a short introduction on severe malaria. So this condition affects a lot children under 5 years old and pregnant women. So you have different types of severe malaria. You have renal failure, cerebral anemia, acute respiratory distress syndrome, and cerebral malaria. Today we'll focus only on cerebral malaria. So it's one of the main neurological complications with Plasmodium falciparum. You get coma and death. And you have currently a mortality rate of 20%. And the main issue, we have 25% of pediatric survivors, they still have some neurological issue. The reason for us would be quite important to develop a drug specific against cerebral malaria, not specific against the parasite. So the main issue during this pathology is you have the cross-presentation of the malaria antigen by the endothelial cells in the brain, and so the cytotoxic T cells attack directly the brain-bone barrier. But the story is not so simple, and I will show you later on. So historically, we have a lot of drugs available against malaria parasites, but very quickly, as you can see with these black arrows, you have development of resistance against all of these drugs. So today I will mention about Methylene Blue. You can see it's a very, very old drug, but the beauty of this drug, because it was not used widely, you don't have so much resistance. Nobody was able to demonstrate any resistance against this drug. So the idea is to see if Methylene Blue could be used not only as a drug, but also as a model to identify biomarkers in the blood to understand what is going on when a patient arrives in the hospital and this patient will die or not of cerebral malaria. So come back to Methylene Blue. As I mentioned, it's a very old drug. So it was the first synthesized in 1876. And it's important to know that it's the first synthetic compound against malaria. So it was shown that it's efficient against Plasmodium falciparum, so some strain resistant against chloroquine. And so we published also some nice data showing that it's also efficient against Plasmodium vivax, and particularly against chloroquine-resistant strains. So in terms of dose, usually you can use intravenous 1 to 2 milligrams per kilogram, or it can be used orally. You have some very low toxicity, some side effect because it's a dye. Of course, you have some green urine and blue feces. It's one of the main reasons why it was not used widely, and now people can revisit that. You have some issue with the gut, but with much higher dose. Same issue also with G6PD deficiency, but if you are using the right dose, you can use also with G6PD patients, and it's important to know that these mutations are present in a majority of the tropical countries. So this drug was used several times in combination with artesunate, with with primaquine. So as a companion drug, is very, very, very efficient. And because we have development of more and more drug resistance against all of these malaria compounds, is very helpful as a second line of defense against the parasite. So here you can see the main difference between artesunate and Methylene Blue. So I will not go so much in details, but the more important point from this slide is to understand that the mechanism of action of the drugs is totally different. So meaning that now we know that from Southeast Asia and now in Africa, artesunate is a base drug, but we are more and more resistant against this drug. So we can still hope that we can use artesunate and Methylene Blue in combination to avoid the spread of all of these resistant strains. So cerebral malaria, so one of the main hypotheses is to understand where is the physiopathology of these conditions. And you know that a lot of things happen in the brainstem. So you can see with this event reference. And more importantly, due to mouse model, we know that brainstem is a main tissue in the brain where you have fetal cerebral malaria. So just one point on Plasmodium coatneyi and why you are using this model as a surrogate model for Plasmodium falciparum. So in terms of life cycles, this parasite are 48 hours life cycle like Plasmodium falciparum. In terms of morphology, we do a lot of scanning electron microscopy in my lab. So when the cells are infected, you have formation of this small structure at the surface of the infected red blood cell called knobs, and these knobs are responsible for the cytoadhesions of the parasite in the brain and involved in the sequestration of the parasite and formation also of rosettes. So rosette is when we have infected red blood cells able to bind to uninfected red blood cells, as you can see on the scanning electron microscopy. And this will also increase the sequestration of the parasite in the brain. So this study today, so we are able to use different macaque rhesus. We harvest the organ to do some RNA-seq analysis, and we identify some biomarkers in the blood could help us to understand what is going on in the patients. So we have 3 groups of macaque with different doses of methylene blue, and 1 group of untreated macaque here. So I'm happy to say that this paper was recently accepted in Nature Communications. So 3 different doses. We use splenectomized macaques because if you don't splenectomize macaques, you don't have the severity of this infection, as you can see on this graph with the parasitemia. And we start to treat the macaque during the cerebral malaria window. So it happened just at day 7 and lasts until day 12. For ethical reasons, we have to euthanize all of the untreated groups because this pathology is very, very severe in rhesus macaques. So here you can see in terms of histopathology, so in the cerebrum, cerebellum, and brainstem, so after treatment, we reverse completely the physiopathology, and we cannot detect any more pigment. So hemozoin is a pigment generated by the parasite inside the red blood cells. In the liver, after the treatment, you continue to see the hemozoin because the liver has a role in how to clean the blood, and so all of the dead parasites are already going inside the liver. So now in terms of transcriptome analysis, you can see on this dendrogram that you have a very nice clusterization of the non-cerebral tissues, and you have another clusterization of the cerebral tissue, as you can see, with a different pattern in terms of transcriptomes. If you dig a bit more specifically on the 3 different types of brain tissues, so brain stem, thalamus, and cerebellum, you can see we have on this PCA, we have very nice clusterization, particularly for brainstem, between the untreated macaques and the naive and the treated macaques. So for the rest of this study, we focus only on brainstem because you can see the clusterization is not as good as the brainstem for cerebellum and for thalamus. Here's just to show you on the schematic the similarity between the macaque brain and human brain for thalamus, brainstem, and cerebellum. So we did the DEG analysis, and as you can see here, we have like 801 DEG for the infected and untreated when you compare with the naive group. And also we have 1,709 DEG when you compare the infected, treated, infected, untreated. So it's starting to be a lot of DEG. So after we dig a bit more and we just compare what is the common DEG between these two groups, we end up with 574 DEG. So when you can see on this heat map, and you look at the profile, the profile of the DEG, we have a very nice pattern showing that when we treat the macaque, you reverse completely the phenotype due to the infection, as you can see here. So that was quite interesting, but this list of DEG was already too long to speculate in terms of biomarkers. So we continue our analysis, and we are quite happy and surprised to see if you are looking for the top 20 pathway of analysis, the first one is linked to the granulocytes. So as I mentioned initially, the main model for the physiopathology of cerebral malaria is due to the cytotoxicity on the brain-blood barrier. But majority of the study are done on a mouse model. So it's the reason a lot of time people underestimate the role of the granulocyte in a malaria model. We did also another pathway analysis, and you can see neuroinflammation is central in cerebral malaria. That is not new, but more important things we can see very close to this neuroinflammation is the role of the granulocyte in terms of adhesion and diapedase. So we start to see that maybe the neutrophil could be important in the development of the physiopathology for cerebral malaria. So we continue our analysis, and as we mentioned during this congress, we try to reduce the number of animals when you work in biomedical research. So we start to combine our dataset with two other datasets. So one human dataset using only blood samples. This was a microarray with a bit limitation in terms of analysis, but we are able to use that. And we use also another dataset from the same type of macaques, so macaque rhesus, but same thing using blood. And before and after and during the acute infection, same thing in the blood. It is important to know that in our data set, we don't perfuse the brain, so we have the information from the brain tissue, but also from the peripheral blood in our data set. So we combined these three data sets, and what was nice, we were able to identify only 9 common DEG for this analysis. So now we're starting to touch a nice panel in terms of biomarker for the severity of this physiopathology. So here you can see the heat map. So as I mentioned before with the 572 dataset, so when we treat with methylene blue or coatneyi infected macaque, you can see the reversion of the phenotype when you compare with the naive macaques. If you do the same thing between patients with mild and cerebral malaria, you have the same profile with these 9 genes. If we come back to the dataset from our colleague from US, between pre-parasitemia and acute phase, we have the same profile. We reverse completely the phenotype. So that was very good because, as I mentioned, for this study, we tried to identify what are the markers for fetal cerebral malaria. Because some patients, they go to the hospital, they are in condition of cerebral malaria, but they are not going to die. So if you want to find a drug specific against cerebral malaria, you need to be able to identify this phenotype and which patients should die of this condition. So after, for the validation of our biomarkers, you can see on this violin plot, we have very, very nice segregation between the infected, untreated macaques versus the naive one and the infected and treated. After, if you compare our panel of biomarker with the current cerebral malaria gene signature in this kind of publication, you can see you don't have a nice segregation between this treated and naive versus untreated macaques. So we extend our analysis, and we are using a majority of the public dataset available against malaria and severe malaria. And with our 9 genes, we are able to have this nice segregation between cerebral malaria here in red. In green, you have severe malaria anemia. In turquoise, you have unplicated malaria, and here you have LT patients. So very, very nice segregation between the different type of mild and severe malaria. After, because it was one of the questions of the reviewer, we try to see if we can maybe see if we are very specific in terms of encephalitis to malaria, or if it's also affecting other viral infection. So we use this data set from West Nile virus infection, and we're happy to see that we are very specific of cerebral malaria. When we have another viral infection, another infection due to virus inducing encephalitis, we don't have a nice segregation between the two types of patients. So in terms of biomarkers, we try to see with our 9 different markers in which type of leukocyte subsets are expressed, and you can see 8 out of these 9 biomarkers are present in the neutrophils. So as I mentioned, a lot of studies were done on mouse, and we know that in the peripheral blood of mouse, you have a lot of T cells, but not so much neutrophils. So the is quite biased in terms of analysis for cerebral malaria, because mouse is one of the best well-known model for experimental cerebral malaria. Not so many people are able to use monkeys. So just to summarize, in infection of coatneyi in macaques exhibits numerous features reminiscence of Plasmodium falciparum in human. So we think we have very good models later on to screen different type of drugs. So currently we are working with our colleagues from Maidol, Oxford University, to see how we can use these biomarkers in a human cohort. Methylene blue treatment is protective against cerebral malaria. So it could be good to revisit these very old drugs because it's a very cheap one. It's available. Toxicity is very low. So in Africa or some part of Southeast Asia, it could be very used to use this drug because now we have more and more drug resistance against artesunate. And another thing that we're just starting to explore with our colleagues from London and because they have a cohort of infected patients in India, is to see what is the role of the neutrophil in physiopathology of cerebral malaria. So I would like to thank my team, and first of all, Jingwen and Yuai, my former PhD student. They were in charge of this study. And very importantly, I would like to thank the US Army based in Bangkok in Afrin, because this work was done with all of the vets, and you can see it's quite hard work for them because we have a very big cohort of infected macaques. So thank you for your attention.